Next up, Dr. Angela Ofori-Atta. Professor Atta is the founder of Psych, chairperson of the Ghana Psychology Council, a practicing clinical psychologist, and the immediate past head of the Department of Psychiatry. As I mentioned earlier, her full bio is on page 8 in the conference booklet, but she'll be talking about her Psych Ghana, expanding access to mental health care.
I was just wondering how this goes. Well, good afternoon from a very hot West Africa. It's a real pleasure to be here. Thank you for having me. And I think I just registered this morning to be a member of the AGMHI. Yes. So I'm here to talk about the Psych Core when okay, in a minute. But let's say 12, 13 years ago, we were just wondering how to improve on access to care in Ghana. And as you well know, it takes about 6 years to train as a psychologist. It takes another 8 to 10 years to train as a fully fledged psychiatrist. And we knew that our communities couldn't wait that long for us to produce enough people to work in the field. Social work's another 4 years and so on. And so we looked around for models of care. And we, being University of Ghana Medical School, Department of Psychiatry, dare I mention Yale to some people in this room. We had collaborators in the public health school. And we just found a model here in South Africa where there was like 5 years of 5 years of undergrad training topped up with, internship and a year of service, and then to the community, and then you had your clinical psychologist. And we thought, who knows more psychology, general psychology in Ghana than undergrads who are just graduating? So that became our core group, and we thought we would add some psychological first aid, applied psychology, and voila, Psych Core. And so that was just over 10 years ago. They're still alive today, and I want to tell you a little bit more about it if we can have the slides. 1 minute, it's gone from 4 minutes to 1 minute. We're getting there. So basically, 10, 11 years ago, we did not have much access to grants, to do research. We didn't have, or to change anything in mental health. And we'd just been doing the same things over and over again. We maybe had 10 practicing psychiatrists for a population at the time, and maybe under 25 million, 10 psychiatrists. We had 2 PhD level clinical psychologists from the University of Ghana Medical School. We had trained quite a few at the master's level, but they weren't hired as clinical psychologists in the healthcare system. They were either teaching or working for NGOs and so on. So that was the situation 10 years ago, which is why it was really important for us when we hit on the idea of catching them young, right after school. The other thing that was useful for us was the fact that we had national service. The national service is when you finish your degree program and you're posted anywhere in Ghana to do anything that you're asked to do for a year. It's like your give back to the nation. And there's always money for it. Whatever the government does, the government always finds money for national service. And so we thought, okay, this is sustainable. So we went to national service and we said, can you help us? They said yes. We went to the Ministry of Health, Ghana Health Service. We said, do you think you can accommodate our young psychology graduates so they bring a bit of psychology into your work? And they said, okay. So that's what we did. And we thought we would make it by force. You know, it's national service. You can be sent anywhere. Why do you have a choice? If you've done psychology, you should be able to do this. You should want to do this. So we had at least 200 people who had done clinical psychology. Oh, good. Hang on. Thank you. So I've explained this already. I'm just going to take us back a little bit, rewind, because it's important that during that time, the kind of thinking that was going on in mental health in Ghana led to the passage of the Mental Health Act in about 2012, and it was part of this push towards improving access to care. And then in March 2023, all the way 10, 11 years later, we decriminalized suicide. So that's just two big events in a decade. But in the middle, well, just before that and running through all of that was the Psych core. So we did visualize it as a task-shifting exercise. And we visualized it as a way of not setting aside mental health professionals, which is what many psychologists thought we were doing, and they were not happy with us in the beginning. In fact, they opposed us quite a bit in Ghana. But we also were a bit naive. We didn't push the idea that it meant that we were deepening the profession, because you would have psychology assistants, as it were, and that then the professionals would be the supervisors, the trainers, the researchers, and so on, have more bandwidth to do that kind of work. And in mental health, you would, to do good task shifting, especially in the clinical areas, you would have to define the tasks that you could shift onto, as it were, lower trained cadre. So screenings and assessments, psych education, engage service users in treatment, help patients achieve symptom reduction, and manage the risk of relapse. This is a beautiful map of Ghana showing you where there are few NGOs providing mental health care. The blue circles are teaching hospitals. The regional hospitals with psych units are in green circles. This is not covered completely. The country is not covered completely. And then we have actually 3 specialist hospitals. So one is missing. One is covered by the blue ring to your right. It's over there. So they're all in the south, the specialist hospitals. Okay, so fast forward, currently we're almost 31 million people, and we approximate that 13% of us suffer from some mental disorder with some level of severity, or varying levels of severity. But only about 2 to 3% of those who need the care will get the care from us, as in the Ghana Health Service and other orthodox treatment centers. Here's another way to look at it, which is the prevalence of mental health and substance use disorders, sort of 2019. They've done a few adjustments to the raw data to give us this pattern, as accurate as it can be in our data sets that are not so accurately collected. But this is what currently our resource pool is. And, oh, okay. So you can see, if you look down at the psychiatrists and the residents, we have about 69 specialists, and we have about 49 residents. And that is, for us, a huge improvement from the 10 years ago. And for psychologists, we have quite a few as well, 244. Not PhD level, but better trained clinicians at the master's level. We have mental health social workers, we have mental health nurses and occupational therapists. So we're not doing too badly. When you look at this, you can see that the biggest rate per population for mental health resources is in nurses. And so we have them as community psychiatric nurses, MAPS, they are very experienced psychiatric nurses who go for 2 extra years of training and they can diagnose. We call them MAPS. And so they're an amazing resource, and they run the community psychiatric services around the country in more than half of the districts of the country. So that tells you that there's still room for task shifting. And these are patients treated in mental health facilities. The outpatient facilities, as should be, have the most numbers of people. But what is the Psych's organizational structure? It's very loose. So you can see that we have trained clinical psychologists and supervisors in the Kolebu Teaching Hospital and the University of Ghana Medical School. They form like the board of directors, and for all of these years have also been the trainers. And then we have 2 or 3 coordinators who are very early career psychologists who coordinate this for us as part of their training internship. So they recruit and organize the training for students from the University of Ghana Medical School. This is really key because we don't have a grant. We don't have a building. We don't have standing staff, but we've been going for 10 years. So these, early career psychologists help to recruit and organize the training for students, and then we train the psychology undergrads before they're deployed by the National Service Secretariat. So once they get into that system, they're paid as anyone doing their national service. And they enter into hospitals, schools, community settings, and they do all kinds of things that are required in mental health. Okay. So we wanted them to identify mental health conditions and bring them in for treatment with the community psychiatric nurses, or if they had psychologists in the districts, they could bring them there, or doctors in primary health care. They were supposed to provide support, including psychology first aid and lay counseling, collect community data on cultural influences on mental health perceptions, assist in tracing non-compliant patients, those no longer coming for consultation but needing it, and encourage them to seek help, and conduct educational talk on mental illness, drug use, teenage pregnancy, sexual abuse, and so on. So these are the settings in which they work. The most being in the general hospitals, because in the general hospitals, you had the community teams based there who then go out, or the district health management teams. So this is a great place to hold psych education under the trees. As you can see, our numbers over time decreased, because as I was telling you, we made it compulsory in the beginning, only to discover that the Psych Corps found ways around. Some of them had parents who didn't want them working with mental illness, patients with mental illness. Some of them got more exciting offers with the banks and so on, and they preferred to. So over time, we made it voluntary, and now we end up with a core of between 40 and 60 who stay with us, and we think that's a good number. But I think when we revamp it, hopefully, it'll be more exciting, and we'll have more people in there. I'll just skip that. How do we do our training? Which is, I think, something that was more what MHI wanted to know about. Well, we don't have any resources, so we were really pleased. Well, University of Ghana would give us their classrooms, which was very good. But since COVID, Zoom has become more and more useful to us. And like I said, it's us in the Department of Psychiatry doing the training. Our curriculum was actually something we gleaned with Yale University. They had a similar program going at the time, and one of the advocates, a psychiatrist, was from Syria, and we're very proud that he went back to Syria during the war to offer this kind of help. The role of, so our curriculum is very simple. What's the role? Remember, these are people with 4 years of training in psychology. So the role of Psych Corps in the community, what they're supposed to do when they get there, case finding and referrals, to work with the community psychiatric nurses, basic communication skills, structuring a conversation in the field. How does a young person enter a community and begin to talk about mental health? Life events, coping, and recovery. So because they've all done basic psychopathology, they could recognize some level of serious mental illness and not so serious. And so we would add to that if there's trauma, if there's accidents or climate events, if you like now. This is the kind of thing that you would do. Offering support in times of crisis. Ethics, we had to learn very quickly that we needed to talk to them about what was proper, what was not proper, and some level of professional ethics, because when they went, they were called psychologists, they were called clinical psychologists, and in Ghana, you can't call yourself a psychologist without a master's degree. So, and then, interestingly, the health personnel were so happy to have somebody with a psychology degree. They kept giving them the most serious mental illness. This is to look after. And just one thing that that I'm reminded of is we do the supervision on WhatsApp platforms, because we can't be everywhere, and it seemed to be very helpful. One day, I just happened to look on the platform, and this message comes rolling in. Help. I have an agitated patient with me. What should I do? And the response comes from another Psycho member. Run. And so, it was like, hey, wait a minute. Just sort of you know, can you sit? Can you walk with them to the nurse's station? What can you do? You know, it was really interesting. Anyway, but we had to carve out the boundaries for them because everybody wanted them for their work. And it was really interesting. We went back years, maybe 4 or 5 years later, and worked with the Ghana Health Service on onboarding them properly. So this was all learnings on the road. And then we added self-care and the supervision element in the Psych program to prevent burnout and to help them deal with the burnout of their colleagues, the people they found in the Ghana Health Service as well. So we did a brief survey recently on what they thought of their the training and which was their favorite. Interestingly, I think the favorite was ethics. The ethics of lay counseling, they said, that was their favorite. And the second big one is the light blue one. Let me see. The role. How to identify mental illness, which we thought they had down pat in psychopathology, but they don't have. And then the other one is the role of psycho in the community and case referral. So we were quite pleased that they actually enjoyed. And these are just a few quotes on what they thought was useful for them. I'll just read one. It's the best program initiated to close the treatment gap in our country. There should be more awareness so that most students in psychology will join and make more impact. The other thing we hadn't thought would happen is that they would stay in mental health. I guess we hoped they would, but to actually have them remain in mental health and do graduate programs, we've had to write quite a few letters to help get them into grad school. How are the Psych members supported? Of course, we give the orientation in applied psych and clinical work. We have a training manual which we share with them. We have field supervision by the community psychiatric nurses and psychologists they work with. We have field visitation when we can from the young psychologists who work with them. Our partners have been Yale, of course the University of Ghana, psychology and psychiatry departments, the National Service Secretariat in the middle there, the teaching hospitals, the Ghana Health Service, and there's a young group of diaspora and undergrads who want to bring psychoeducation to the secondary schools and set up mental health clubs. And we're going to carry them as our way of beginning this kind of bringing in new interventions, testing them, and having like, how do you call it, machinery on which to roll such programs like this. We've had some impact, we believe. First, in community mental health, when there have been disasters, we've been like the first non-medics to show up. We think that by bringing young people to talk about mental health in Ghana, that we reduce the stigma associated with mental health. What we do, we think, may prevent PTSD. And so, for example, in 2020, during the COVID months, we helped to provide a national COVID-19 helpline. It was one of the things the Psycho did. We also helped set up a suicide prevention call center for the Mental Health Authority. Now, this goes back to 2015. We had a huge fire and flood disaster in Accra. Before even nationally we could organize to help the victims, we set up camp there with the Psych Corps because we could move them quickly. And then we also got the psychiatry residents and clinical psych master's students there on site. Couple years later, there was a huge gas explosion just behind the University of Ghana, not too far from another university and a high school, and it was quite traumatic. And before we knew it, psychiatry residents were there, supported by the Psych Corps to help residents and go through that. And this is more recent. We have climate change. We have a lot of water behind our dam. The Akosombo Dam is the second largest man-made lake in the world. And when it was built, all of that land was bought for spillage purposes, compensation paid all the way to the sea. And we've had a number of issues, community-related issues where the communities near the estuary will not allow dredging and so forth because it disturbs the fish. And then we've had more rain than we should have. And so now we have, with the spillage, we have huge floods in areas of farming and displacement. And this is one in which, because of our previous engagements, and I have to say our psychiatrists now, who are now specialists, are very ready for national disasters, and they've just jumped in, and psychologists have jumped in, and we're like, aha, you don't need us anymore in these matters, do you? So we now have to pull back as Psych Corps and think about the gaps in prevention of trauma in our neighborhoods and actually educating people about their mental health. So that's a good place to be, I think. So we've moved into continuous professional development for professionals demanded by the Ghana Psychology Council, Mental Health Authority, CBT training, and so on for professionals. So we're sort of going up the ladder in that way. So what are the future directions? We are thinking that instead of just this short top-up program, we should start the clinical applications of principles and so on earlier. So it's a certificate course along the BSc BA course. So that's one. And then just making that machinery so ready to roll out psych education, psych first aid, programs like the Friendship Bench, mental health clubs, and so on. And then also having the legs ready for big research. So that's their year of national service. Imagine these young people just getting into the field like that. And then the education service is an unexplored area for psychology in the sense that there's so much need for children with learning problems, behavioral problems, and so on. And you have this core that just needs a little bit of orientation, and they can go right in there and help, and with large class sizes and so on. So that's it. Thank you.
Thank you, Rick Walthusen at Duke University. Beautiful presentation, and I had like two quick follow-up questions. One about You talked about the treatment gap, and you showed a map of psychiatric facilities in Ghana, and as you said, it's mostly concentrated in the south. So I'm curious how many corps people actually go to the north of Ghana. And I saw that all the quotes were from people from Accra, actually. And then you also skipped the one slide which showed that Accra had the highest.
Yes, I hoped you would not notice that.
Oh, yeah, sorry. We can go straight to the second question.
No, go on.
No, but I'm curious, the national service is do people decide where they want to go, or they get assigned?
Yes, when we started, it used to be that you didn't have a choice.
Yeah.
You went where you were posted. But more recently, they give the service people a choice.
Okay.
First, second, and third, and they try and meet you in one of those areas. So there were years when it was very difficult to get anybody in the north. But this year, I think we have one or two in the north, the northern region.
Okay.
Yeah.
And then the second quick question was about your collaboration with Yale. It sounds like you were developing the curriculum with their help. Now that you have done this for 10 plus years in Ghana, what are some of the things Yale has learned from you so far?
Well, once we set it up, unfortunately, our main collaborator went off to VASA to become the president of VASA. So I think that whole team kind of what do you call it? Crumbled in that sense. So we haven't continued the work with Yale. But it's one of the things that we have been saying we need to do a much more in-depth evaluation of the program and then retool it for the next 10 years. Yeah. So we would actually be very happy if anyone knows how to do these things to come alongside us and do it, because then we would have to be very honest if somebody came from outside to evaluate it.
Good afternoon, all. My name is Benita Lushimaki from Nigeria. So thank you, Prof, for that presentation. I was just curious about how you're able to, regulate the practice of psychology among those young people you have trained to go out there and represent psychology in the field. Remember, they are not professionals yet. So how do you ensure that they are not going beyond their boundaries? Yes.
That was the main reason why we introduced the ethics component. And then they don't work on their own. They work with community psychiatric nurses out there in the community. They have direct supervision from them. And we pray that they also, we know they have an ethics code, the nurses have an ethics code. And so far we haven't received any complaints in that regard, because we really drum it into their heads. After the first year, we knew we would be in trouble if not. So we keep saying, you're not psychologists yet, you are, and we register. They can be registered as psychologist assistants by the Ghana Psychology Council. So they know there's their boundaries.
Okay, it's okay.
Keeping fingers and toes crossed in that regard.
Good afternoon, and thank you very much, Prof, for a very interesting presentation. And I think it was quite eye-opening in terms of a positive model of task shifting. So I think that was quite interesting for me to listen to. I wanted to ask also in regards to the slides that you showed, because when I looked at the theme of your talk, expanding access to mental health care, and then looked at the distribution of where you placed the psych core, and how a majority of them actually still were placed within hospitals as opposed to within the community. I know that in assessing, you looked more so to their experience of the program, and I just wondered how that translated to impact specifically in regard to access. For the communities. So I'm just wondering if you've measured that in any way, or if there's any learnings from from this 10-year sort of pilot, as it were, that could impact how you roll it out going forward, and specifically addressing access?
Well, when we began more than 10 years ago, there were, I can say there were no psychologists hired in the Ghana Health Service. So they, working with community psychiatric nurses, was bringing access to psychological first aid interventions, and helping families, make the step to come for care. So they worked in places where the community psychiatric nurses, even though they were based in hospitals, they would go out into the community. And it was usually to diagnose and give medication. And then these young ones would come and they would talk about, what you have, what makes it worse, what makes it better. I could help you relax and sleep a little better with relaxation training. Oh, I'm sorry you've lost somebody. I'll sit with you for a bit. That kind of very, very simple interventions, and having these graduates there in this rural or semi-urban environment. But now that most of them are in Greater Accra is mostly urban, but we also have that same model for going out into communities. So the medical school, for example, is close to a fishing community. So you're in Accra, but you're still impacting an almost like a semi-rural, semi-urban environment. So the access to care that it opens up is access to psychological care for now. And we're hoping that where they've managed to go to, say, the Volta region, and the other regional places they've been, has been maybe making it more available geographically. Yeah. Thank you.
Hello, good afternoon.
Afternoon.
My name is Darik. I'm from Chicago, and I study clinical psychology in Boston. But I have spent a good amount of time with family in Ghana and lived there for a short period. And kind of building off, thinking about accessibility is, what we often talk about with mental health on the continent is stigma. And even when folks do want to access it, there's still a lot of stigma. So in Ghana specifically, there's often talks about that being a barrier, spirituality, cultural differences, things like that. But I'm wondering for the students, the corps, I guess I'm curious about the aspects of youth that make them want to get involved despite those barriers. Obviously, there's a generation of young people who are like, who work with you and like are eager to understand mental health and psychology. And I'm wondering if there are certain themes, experiences across their upbringing, maybe their households, their perspectives, or things that they've been exposed to that make them want to go beyond the messages that have come from previous generations and saying, let's get involved. So I'm wondering if you could speak to some of the folks, the experiences or perspectives of some of the folks that you've been able to mentor and guide through this pilot program.
Yeah. And we haven't asked them, why do you want to be with us? We're so happy when they say they want to be with us. We don't ask. But I am sure, many of us in the field, it comes from personal experiences of loved ones, family or friends that urges us on. And then once you start reading about it, you're like, oh, it's actually all of this knowledge behind this. But I'll write it down. It's an easy poll to send out to them. Yeah. So, thank you.
Thank you. Thank you again, Dr. Atta.
Okay.